Okay, so what we're going to do first is we're just going to do an ultrasound scan of this lady's chest before we do a pleural aspiration. So on the CT, she's got a large pleural collection, and what we want to do is take a diagnostic therapeutic pleural aspiration today, but we're going to use ultrasound marking, and then probably what she'll need to have done after that is a medical thoracoscopy. So just putting the scanner on her here now. This is a curvy linear probe. The first thing we're going to do is try and identify some underlying pathology. So just down at sort of between 3 and 6 o'clock there, you can see a line which represents the diaphragm. It's echo bright because there's pathology above it. So you can just see above that there's a large black collection of fluid there. At the top of the screen you can see her subcutaneous tissue, and you can see that it's going to be about 2 to 3 centimetres to get into that large collection there. Just try and have a look at her underlying structures as well. So because we're on the right side, we're going to have a look at the liver. If you can just press auto on the bottom of that for me, on the bottom screen, yeah, that's fine. And that auto optimises it because it's perhaps not the best echo subject here. What you can see now is you can see a different texture to the organ underneath it. Yeah. I can't see any ducts through there, but there is some overlying bowel gas there. Then what we're going to do is have a look up here, and now you can just start to see the lung coming in there at about 6 o'clock at the bottom there. Yeah. It's not moving around very much, which can signify an underlying trapped lung, and she's certainly got a large collection under there, and we know from the CT scan that she's got collapse under there as well. So just having a little look further up here, and you can see that that effusion goes right the way up to the top there. Okay, and as it's coming down again down here now. So, yeah, so that's a really large effusion there, and possibly some underlying trapped lung there as well. So we've got a really big space that we can use for marking here. So I'm just going to use the back end of the plastic of a needle. All I'm going to do now is just pop a plastic tube on your back that just marks the position that we're going to go into to get your fluid off. So I can just feel the intercostal space there. So just going to pop this plastic in. It's a bit sharp, I'm sorry. So that just squeezes in. That's our X marks the spot now for when we do our pleural aspiration. And then again we'll just scan over the top just to make sure that we're happy with that position. So we can see a large fluid collection there. We're away from diaphragm, any other internal organs, and there's about a 2 to 3 centimetre depth to get into for that collection, so I'm happy with that marking. Okay, thank you. Closer for this. Yeah. Okay, so this is a diagnostic therapeutic pleural aspiration. We've already used an ultrasound scan to identify the safe place to go into, and what we're going to do now is just clean the skin. So you can just see the mark on the skin there. That's an X marks the spot. I'm just going to clean around that. Then what we're going to do is pop a drape on. Let's just pop that on. And then if you just put it on straight at the bottom, it's got a sticky part on it. Okay.
So just underneath the area that way?
Just straight underneath the area that we're going on to here. And then it's just going to be folded up at the side here, just so that you can...
Same on this side?
No, just this side, because that's the side that we're going to do the pleural aspiration. Okay. Then we're just going to cleanse the skin again, if you want to do that. That's just with Chloroprep. And just while you're doing that, I'll just draw up some lidocaine. So okay. It's 1% lidocaine. It's 100 milligrams. We tend to use 1% here because you get a better volume of distribution. But there's a maximum of 3 milligrams per kilogram, so you need to be aware of body weight. Yes, that's drawn up. What we're going to do now is just start to give some milk anaesthetic. So if you want to give some subdermal lidocaine into the 4 quadrants. Yep. So just have a good feel there now that we've cleaned the skin. So what you're going to do is you're going to give it at 12 o'clock. Quite a shallow injection.
Okay. It's like a skin blur.
Patients, yeah.
Right, sharp scratch.
And then if you just bring it up to 12 o'clock, what you're going to do is you're going to give it into the 4 quadrants. So aspirate and infiltrate into the 4 quadrants. That's done blood there. You can just see the blood coming up there. And give some at 9 o'clock and give some at 6 o'clock. You okay there? Sorry, this is a bit stingy, this bit. Just come out with that now. And just give that a minute or so to work. And what we'll do is we'll change the needle over to a green needle because we're going to give deeper infiltration in a minute.
Okay.
And if you remember the scan we did, we saw that we were going to get fluid at about 2 to 3 centimetres depth. Okay? So what you're going to be doing is you're going to be going in through the skin.
Yeah.
You're going to go over the top of the rib to avoid the neurovascular bundle.
Yeah.
You're going to be facing the opposite shoulder tip. And as you're going through in, you're going to be aspirating and infiltrating until you get pleural fluid.
Okay. So facing the opposite shoulder.
So facing the opposite shoulder tip. So use that angle. Just check for a local anaesthetic effect now. You're going to use the same puncture point, so just check if there's any sharpness.
Can you feel me touch it there? You can?
Still feel that, yeah? Okay, just give that another second. Just give it another second to work. Is it sharp or is it just the sensation of being touched?
The sensation of being touched.
Okay, great. Okay. So at this bit, it's really helpful if you get your hand against the chest wall. And you're going to go in exactly the same angle. And you're going to be feeling, so as you're going through, you're going to be aspirating and infiltrating. Okay? So put your hand against the wall. And just go exactly the same place that you've gone into. So you know that's where we've scanned.
Yeah.
And yeah. A little bit more pressure because this needle gauge is slightly bigger, isn't it? So you're going to be aspirating and infiltrating as you go. And just give a squirt. If you touch the periosteum of the bone, it's quite painful, so just give a good squirt of lidocaine there.
Yeah. Further in it.
Yeah. If you feel like you're touching bone or anything like that, you should just be able to go
Not
straight
yet.
through it. Oops, sorry. Just aspirate and infiltrate. A little bit deeper. You're starting to get pleural fluid there. So once you get pleural fluid at that position, what you're going to do is you're just going to insert tiny little bit more, just so that you get through into the parietal pleura.
Yeah.
And then just take a good aspirate now. And always make sure that you can see that's coming away nicely.
Yeah.
Okay, that's fine. So remember the depth and the angle that we've gone in with that.
Yeah.
And what you're going to do is you just come out now. Okay,
Just
so
come out
piece
then.
up a piece of gauze. Just put that straight over. Okay. And then you can let that local anaesthetic take effect while we get the kit set up. And I'll just show you setting up the kit here. So with all the sharps in here. So this is a pleural aspiration kit. What we're going to do is we're going to get that set up. So we're going to put that out on our sterile field ready to set up. We're not going to use the needles in this, we're going to use a cannula for safety purposes. And what we're going to use is a grey or a wide bore cannula. So you basically take the two ends of the cannula off here, put your syringe onto the end of it.
Yeah.
You don't need to put the syringe onto the end of this, but what you don't get with this is you don't get a flashback like you would with blood. So that's all ready to use in the procedure. And then what we're going to do is we're going to set up the kit here. So you just need to lock this down because when it's autoclaved, just your connections are slightly loose. So just take the little lock end off this. Pop yourself a syringe onto the end. Now the reason you put this on is in case you have to aspirate, but usually gravity does all the work for you.
Okay.
Then we'll open out this bag, that's all ready. And then we can use this sterile towel on the bottom here to pop on the floor. So if we put the bag down there on a sterile field, then gravity will do all of the work for you. So don't stand on that, just to keep that nice and clean. Now what you're going to do, because you've probably got a really good local anaesthetic effect now, because you've taken a few minutes to set this up, you're going to try and get some fluid back. Let's just get rid of a bit of that fluid here. And you're going to go into the same depth and the same angle that you've gone into.
So just do exactly the same.
Exactly the same. So just go
We
around.
might need
just
a
get
new
your
syringe
angle.
or anything.
No, don't need a new syringe. So again, find the point that you've gone into.
Yeah.
Hand on the wall there, just to anchor that down. And there's a little bit more pressure because it's a wider bore, so just aspirating as you go through, just remembering the depth and the angle that you're going to get your fluid from. Just a little bit of pressure, and actually you might find it more comfortable if you put the flat of your hand right against the wall here, you're balancing the needle on it and everything's really nice and controlled. Okay, so aspirating as you go. Keep going, aspirate. You get your fluid, so just go slightly a little bit further in just to get through into the pleura. Get a good glug of fluid. Happy? And then what you're going to do at this point is you're going to start pulling back the needle and inserting the cannula right to the hilt. And that just goes straight in. You're going to put your thumb over the end. And you're going to get the connection on the bottom of here and you're going to attach that over to the cannula. Okay, you ready?
Yeah.
And that's just a lure lock, so just turn the glue around, okay? And just hold the cannula because you don't want to lose the cannula there. And at that point, what you're going to do is just get the patient to take a big cough.
Okay,
big
big
cough,
cough
sir.
fluid now. Big cough.
Okay, and again. And as soon as your fluid gets to about a 3-way tap on this, so another couple of coughs for me, sir. That's great. Then that'll start flowing. And if I put this down on the sterile towel on the bottom here, just to keep everything nice and super clean, and then what you can do is just let gravity do all of the work to drain that for you.
Okay.
Now, if you're not getting a great flow, you can start moving this around. As you pull it out slightly, you get an increased flow here.
Well, the cannula.
Yeah, I've just pulled that back slightly, but what you can see is your flow starting to increase here now. And that'll just flow into the bag by gravity. If you have a really viscous effusion, or if you've got somebody that's got quite a weak cough, then what you might have to do is aspirate with this, and I'll just show you how to do that.
Okay.
So wherever the blank is on the 3-way tap is in the off position. So if you turn the blank off to the bag at the bottom, so turn that 3-way tap round so it's closed to the bottom. Okay, and then just aspirate with the syringe. And it's quite tough, there's a lot of pressure to do it. And actually this is the way that we were taught how to do it previously, but mostly gravity does all of the work for you.
Okay.
And you'd fill that up with 50 mils, and then you're going to turn your 3-way tap so it's closed to the patient, so wherever the blank is off. So turn that right the way round,
So completely closed?
closed to the patient. So up.
So like that?
Right the way up. It's going to be close to the patient. That's it.
Oh yeah. So,
And just squirt that into the bag, and what will happen is it will just squirt down into the bag.
okay.
But gravity will do all of the work for you, so you shouldn't need to do that. So what we can do is we can just close that off to the syringe now, and you can
Just
see a
let it
really
drain.
good flow there, can't you?
Yeah.
So if you hold the cannula there, you don't need to hold the syringe particularly. And then if you just come and have a look at the fluid coming down into the bag here, and what you can see is a really nice flow of fluid, and it's just draining into this bag. Now the effusion's really clear, so there is a possibility this could be a transudative effusion, but we really need to see the pleural protein to be able to say that for sure. And what you can do now, comfortable, take a seat on the edge of the bed there. So you're in a nice comfortable position, make sure your patient's okay, he's tolerating it okay.
You're right there, yeah?
Yeah, fine.
Yeah, and then just that can drain into the bag. And what we're going to do is going to drain about 1 litre off because it's a diagnostic therapeutic pleural procedure. And the reason we're not going to take the whole lot off is because if we have inconclusive pleural cytology, then what we're going to do is we're going to probably think about a medical pleuroscopy or possibly an indwelling pleural catheter with somebody with a poor performance status and a known malignant effusion. But at the moment, we don't know what the cause of this effusion is, so this is just part of the diagnostic pathway. As you drain the fluid off to get a therapeutic effect, if you drain about 500 mils off, that's about a tidal volume, so you get a therapeutic effect at 500. So you can drain up to 1.5 litres in one go, but we only want to drain 1 litre off because if we need to do something else, we need fluid in there.
Okay.
Do you know what the other risks of draining too much fluid off in one go are?
Since the blood pressure might.
Yeah, so the blood pressure could drop down, but sort of the main thing really is the risk of re-expansion of pulmonary edema.
Okay.
So especially with a cardiac patient who's got cardiac history, you just need to err on the side of caution. You might need to take a smaller amount of fluid off.
Okay.
But that's all draining away nicely there. So how are you feeling now? Are you feeling okay?
Fine, yeah.
Good. Sometimes you get a bit of tightness in your chest as we drain this fluid off. Will you let us know if that happens?
Yeah.
And sometimes it makes you cough a bit. So again, just if you need to cough, it's safe to do so because there's no needles in there, it's just a plastic tube.
Right.
Okay, so let's just have a look how much fluid we've got so far. So you can just see from this bag that there's about 600 or 700 mils of fluid in there, so we're not too far off finishing now. If you lose your flow, then what you can do is you can get the patient to cough a couple of times, and what that does is increases the intrathoracic pressure. And again, you can also start moving your cannula, so just slightly out a bit, up a little bit, and it depends on the size of the effusion, how much fluid's there.
Okay.
It's often quite hard to see in these bags, but if you sort of lift up here and look at the flow down here, you can just see a flow coming down. And you have to imagine that this cannula is a small bore tube, so it's going to take longer to drain than a normal chest drain, which would be bigger.
Yeah.
So that's all draining nicely then. Lovely. So I think just a few more minutes and we should be done. And that's been very straightforward. We're not expecting any complications, but what we'll do is we'll get an x-ray after this just to make sure that there's no track lung, because we were suspecting that when we did the ultrasound scan.
Yeah.
Okay, so that's all draining away nicely. We'd always do a chest x-ray if you drain a large volume of fluid. So if you do about 50 mils as a diagnostic tap and there's no complications, you don't need to do a chest x-ray. But for a therapeutic aspiration, we would always do a chest x-ray.
Okay. So if you're doing a diagnostic, how much would you take?
So 50 or 60 mils, so you can probably get about 60 mils in a Pleural sort of
So you wouldn't
syringe.
need this equipment, you'd just literally take a syringe.
You can basically either use a green needle and syringe,
Yeah.
but obviously that's an increased risk of bleeding with that. So you've got to be confident that you're going to be able to get your fluid out easily enough and you've got a large enough collection.
Yeah.
For smaller collections you need to be more cautious. If you've got somebody that's quite anxious about it, they're in pain, they're in discomfort, then you can do exactly the same technique by giving them local anaesthetic. You use a grey cannula, but when you take the needle out of the cannula, what you're going to do is put a 50 ml Pleural syringe straight onto the end
From the syringe.
and take it straight from the syringe, fill a 60 ml up, because that's the minimum really that you need for this.
Okay.
So I think we're
But
nearly
obviously,
done.
this is a therapeutic, we're taking.
Because he's got a large volume, we're going to do a diagnostic therapeutic. So there's 1 litre of fluid in that bag now.
Yeah.
So what we're going to do is we're just going to get some folded gauze here. You don't have to do Valsalva manoeuvre because it's only such a small bore tube that you've got your cannula in.
Yeah.
So it's literally just popping your folded gauze over the top of it, taking your tube out and putting your gauze straight over the top of that. Okay, and that's out. And then what we'll do is we'll just turn that three-way tap on so we don't get any backflow. I can leave that there, I can deal with it in a minute. And what I'm going to do is just put a dressing on that for this patient that can stay on for about 24 hours. I'm just going to take some of these drapes off for you, sir. You're all done now. Is that okay?
Yeah, fine,
Great.
Leave this on.
Yeah. So just take your fingers away. There's the dressing on. And that's all done. Okay. You can sit yourself up, stretch your legs, and then what we're going to do is we're going to send some samples off for biochemistry, microscopy, and non-cervical cytology. Okay?
Yeah.
Perfect, thank you.
Thank you.
Well done.